Hey there, everyone. Thanks so much for joining me here on Wave Now's Ask the Doc. I'm Myra Ansari with Dr. Emily Montgomery with the Wendy Novak Diabetes Institute and Norton Children's. We are talking about diabetes awareness, something that's very important. And you all shared an interesting nugget of information with me today. I had no idea, but we know that type 1 diabetes is diagnosed more in the fall than any other time of the year. That's really interesting. Dr. Montgomery, why is that?
So I think to explain that, it's helpful to go back to kind of how diabetes develops. And so we know that when your pancreas is functioning, your pancreas makes insulin. And the job of insulin is for you to be able to use all the nutrition that you eat in the day to get that nutrition, it gets into the blood, and then insulin is actually the key that unlocks the cells so that the nutrition can go inside and the cells can use that to make energy. And so when there is a loss of insulin production, like in type 1 diabetes, we see that the body is no longer able to use the nutrition in the way that it was previously. When we don't have insulin present, we can eat and eat and eat and do our best to get all the nutrition, right? But the sugar that we eat actually stays locked inside of the bloodstream and actually cannot access the cells, because insulin is the key that unlocks the cells so the nutrition can go inside and the cells can make energy, which is how our body functions and does all of its things, heart beats, brain works, all of that stuff. And so when the body loses the ability to make insulin, the body is no longer able to use nutrition in a way to make the cells to make energy. So we eat and the pancreas does not make insulin because it's lost its ability to do so. And in doing that, the body is no longer able to use that nutrition. So the blood sugar rises because that nutrition gets stuck in the blood, but the cells actually start starving. So the issue is that without the insulin, the cells stay locked and they cannot access any of that nutrition. Without that nutrition, can't make energy, which is a big problem, right? And so what we see is that people, they become very hungry, right? Because their body's starving. They become very tired because their body's not able to generate energy very well. They become very thirsty and they start urinating a lot more frequently. The reason is that the kidneys see that the blood sugar is high and they're like, oh, we can help out with this, right? And so they start to dump more and more sugar into the urine, trying to get it out of the blood, but water follows sugar. Right? So the more sugar is in the blood, the more the kidneys try to get out, the more water follows that. So the more we are peeing out sugar, the more water we need to drink. And it's kind of this vicious cycle that leads to pretty severe dehydration. So we see when we're looking for people who are starting to show signs of diabetes, we're looking for more thirsty, a lot more urination. They're getting up at nighttime to go to the bathroom and they previously didn't. They're not making it through very many classes at school before they need to go to the bathroom, et cetera. Losing weight, being very tired, et cetera.
So what does the fall have to do with all of that?
Yes. So the way that type 1 diabetes develops is it's an autoimmune disease. And so in all autoimmune diseases, we know that the immune system, which is designed to protect us from viruses, bacteria, different kinds of infections, it gets tricked. And it gets tricked and sees, in the case of diabetes, the cells that make insulin, it sees them as not belonging. It sees them as being foreign or dangerous. And so it mounts a response, and actually the immune system eliminates the cells that make insulin, which is what leads to diabetes. We know that there are multiple factors that play into this development of autoimmune diabetes. Nobody is really 100% sure how the beginning starts with the triggering. What is it that causes that first trigger? We know that there's genetic predisposition, meaning that there are some genes that increase the likelihood that you will develop type 1 diabetes. Okay. And so that likely puts kind of increases the potential that the immune system will get tricked. We also know that there has to be a trigger. So you can have those genetics, but if there's never a trigger, that immune system doesn't get tricked and you don't kind of go down that pathway. And so there are very many different theories about what those triggers are. Most of them are environmental, things like viruses, infections, things that cause the body a pretty significant amount of stress, et cetera. And when we look at the development of diabetes, type 1 diabetes, we know that the beginning is that tricking of the immune system. And there's kind of a long process where there's a very slow kind of change in the body where the immune system does a very slow elimination of the cells that make insulin. And then there's kind of like a point where you fall off and you start to actually see the signs and symptoms of diabetes. We know that some of these triggers can be viruses. And we have also seen that the patterns of viruses in our area and across the world, typically we see a much higher prevalence of viral infections in the late fall and into winter. And so the thought is that, yes, there was something that triggered the autoimmune process to start. So we kind of start down this process, but there's something that creates like kind of a fall off cliff. And often that stressor can be a virus. And so we often see that people present with diabetes when they have had that second infection, which occurs during the time that viral infections are highest, which is in the fall for us.
Oh, okay. All right. So it's kind of like a something that triggers it, or not, or just kind of
like pushes you over the edge. You're already down the path, and then the body's like, oh, this is a little bit more stress than I can handle. You pushed me over. I can't keep up. Now I'm too stressed.
Okay. And that's kind of like the indicator that leads to a diagnosis.
Yeah, so usually that's when we start to see. So by the time you actually show signs and symptoms of diabetes, usually you've lost 85 to 90% of your ability to make insulin.
Oh, wow.
So it's kind of like that, like final push. Like maybe you were making, you're still making 30% and you're doing, kind of like traipsing along, compensating. You weren't having perfect blood sugars or right what we would consider normal, but you weren't all the way either into having higher blood sugars. And so often we see that there's a viral infection or something else that kind of pushes you over the edge there.
What's the difference between type 1 and type 2 diabetes?
Very good question. So there are actually, turns out, like 20 different types of diabetes. I know. Yes, right? We keep all kinds of secrets in endocrinology, And so the primary ones we talk about are type 1 and type 2 because those are the most common. So type 1 is the autoimmune process, right? The immune system gets tricked. We lose the ability to make insulin. We cannot regain the ability to make insulin. Once the cells are gone that make insulin, they do not recover. We cannot regenerate them.
Okay.
In type 2 diabetes, we see a similar issue looking at not being able to make enough insulin, but it's a little bit different in that the body doesn't lose the ability to make insulin. The body begins to demand more insulin to do the same job that it was doing previously. And eventually the demand for insulin can outpace what the pancreas can make.
So is one type worse than the other? That makes sense.
That is a complicated question that you ask, but I think it's a fair question. So the way that we treat them, it can be different. Okay. So in type 1 diabetes, we know that you're insulin dependent. You require insulin to be alive, right? And so when you lose the ability to make insulin completely, we know that that is life-threatening, and we have to begin to replace insulin or you cannot continue to live. In type 2 diabetes, initially what we see is a resistance or a requirement for more insulin than your body was previously making. And so we can sometimes treat that with things like metformin, the GLP-1s, the SGLT2, different ways to help the body to use the insulin the pancreas is making more effectively. Mm-hmm. So basically decreasing that demand to do the same job as before. Okay. We also know that exercise is incredibly helpful for insulin sensitivity. And so doing weightlifting and cardio and different things like that can be very, very helpful, as well as making some nutritional changes.
So is there a certain age when type 1 diabetes is more likely to be diagnosed, and does it impact boys or girls more? Do we know?
Yeah, so anytime between being about 6 months of age until late adulthood actually is fair game to be diagnosed with type 1 diabetes.
6 months?
Mm-hmm. 6 months, yes.
Wow.
Yes.
How would you know with a 6-month-old?
It really is hard because they are like thirsty because they're hungry, right? They're like drinking and they pee all the time because they're babies. Like that's what they do. And so it actually is really, really challenging. Okay. Typically they come in because they have stopped acting normally. They're not waking up like they used to. They are further along in the disease process than, say, someone who's 5 or 6 that you notice like, wow, they're drinking a lot. This is a little bit weird, versus like they're 6 months old. There's not quite as many obvious signs to look for, which makes it a bit more challenging.
Okay. Sorry, I got thrown off by your response because I had no idea a 6-month-old could be. So you said, what was the age range that you just gave? 6 months to what?
Late adulthood. So actually there are many people who are diagnosed with type 1 diabetes in adulthood, which I think is kind of a misnomer people don't expect because we kind of call it like juvenile diabetes previously. Mm-hmm. There are a couple of peaks. So we see between the ages of like 5 and 7, and then again in puberty, we see kind of like a little peak in the rate of diagnosis of diabetes related to, the hormonal chaos of puberty that creates all kinds of stress and growth. So.
You talked about genetics too. Mm-hmm. Let's talk about how that plays. If I have type 1 diabetes, is it more than likely that my child is going to have it, or how does that work?
Yeah. So the overall risk in the general population for type 1 diabetes is about 0.4%, so about 4 in 1,000. When we look at families that have diabetes, there is a genetic component, relates to the immune system primarily. And we know that identical twins have about 70%. So if twin 1 has it, twin 2 has a 70% chance of also developing it, which tells us that there's a little bit of an environmental component.
Okay.
When we look at siblings, we see closer to like a 3 to 6%. So if we're siblings, if you're my sister and you have it, I have about 6% chance that I will develop diabetes, type 1 diabetes. If the mom has diabetes, it's closer to 1 to 3%. But if dad has diabetes, it's about 6 to 10%.
Okay. All right. So we've come a long way. I would assume that in treatment and that sort of thing. What are our options in diagnosing and everything like that?
Yeah, so part of diagnosis is getting an idea of what your blood sugars have been looking like. We check for signs of the autoimmune process that's been going on with autoantibodies, which helps us to identify that the process that took place to eliminate the beta cells or the cells that make insulin was the autoimmune process, which is something that we use later on when we talk about screening. So this is very helpful.
Is screenings tough, or is it fairly easy to do?
It's very easy to do. It's just a blood sample, and we look at the presence of autoantibodies, there are 4 or 5 different indicators that there's an autoimmune process taking place related specifically to the pancreas.
I think I finally went to a doctor and got, I always tell people, go to your doctor. Finally, I went and they tested me for diabetes. Mm-hmm. Thankfully, it came out negative, but it was a very simple test.
Yeah.
And it comes back very quickly.
It does. And so typically that's looking at the blood sugar control. It's called an A1C or a hemoglobin A1C, and it looks at about 3 months worth of blood sugars averages. So that tells us, yes, we're looking at somebody whose body is unable to manage their blood sugar, whether they don't make enough insulin or they're not making insulin at all. And then we do further testing that's very similar. It's also a blood draw for autoantibodies to tell us, okay, this is the reason that caused the inability to make insulin.
So people watching this and they're wondering, okay, should I be screened? What do you do? Who should be screened? Is it something everybody should do? Or is it signs and symptoms? You start to show those, then go get screened? Or what do you do?
This is a loaded question currently. So it's a great question. And it is becoming a little bit more complex. So historically, there have been some studies such as TrialNet that have allowed us to look at people who are related to people who have diabetes. So if you had a first degree family member, if your parents or your siblings, and then in younger children who had aunts and uncles and grandparents that had type 1 diabetes, we started screening because we know that they're at an increased risk, right? Mm-hmm. We know that they're in that 1 to 10% risk category. And so we know that we, one, can prevent them from becoming very, very sick at the time of presentation by getting an idea of who's at risk, who has the autoantibodies, who's headed towards developing diabetes, and monitor and help to intervene earlier. Currently, we continue to screen primarily through TrialNet and different organizations in that research studies like that because we know that those groups have a higher rate and a higher risk. When we look at general population screening, it gets a little bit more complicated. And to get into a little bit of fine detail briefly, we know that people who have 2 antibodies or more have a much higher rate of developing type 1 diabetes down the way. We don't know the exact time frame that will take place during. We know that if you are younger and have more antibodies at that time, you will progress faster and you'll be a younger age when you develop it. Mm-hmm. But if you are screened for the first time when you're 15 and you're positive for 2 of them, it's hard for me to say exactly when we expect you to develop it. And we know that people who have maybe 1 antibody, some develop type 1 and some don't. And so we're trying to decide, the population, the general population doesn't have a very high rate. I mean, it's 0.4%. So it is definitely noticeable and is significant, but it's not like 30% or 20%. Okay. And at this time, we have some ability to delay the onset of type 1 diabetes, but we're not able to prevent it fully. And so we know that 90% of people who develop type 1 diabetes actually have no family history. Okay. So trying to decide, when is it appropriate? When is it beneficial? Are we doing no harm? When are we doing harm by screening? Mm-hmm. When are we telling people, okay, well, maybe you have a risk of developing type 1 eventually? That's really stressful for somebody who has a 6 or 7 year old kid, right? Mm-hmm. Like, what do I do with that information? Are they going to develop it? Do I need to keep paying attention? Are there going to be multiple antibodies? And what is the cost associated with that? Is it appropriate for us to be screening everybody if we know that the population is 0.4% and we can't actually prevent disease at this time? So there's a lot of back and forth about that. We know that there is a medication currently called tezlibimab, which it is a new development and actually pretty exciting. We've worked for a long time to try to get a good idea or a better sense of what type of immune modulation, like how can we kind of teach the immune system to tolerate the cells that make insulin, to kind of turn a blind eye and stop being so aggressive and eliminating them. And it's been a very challenging but very interesting and helpful road where we have learned a ton about how the immune system is actually interacting, how the disease process is taking place. We have learned that it's not always the same. There's a lot of heterogeneity in the way that the disease process develops, which makes it a little bit more difficult to treat. We also know that the timeline of treatment is a little bit more complicated. And so we know that there is an effect in delaying the onset of like requiring insulin in patients who have multiple antibodies, who are also not regulating their blood sugar like they did when their body was making insulin all the time whenever it was supposed to, but they aren't at the point yet where they need insulin. They're kind of in that in between, like their glucoses are kind of in the middle. And so those are the people who currently have the opportunity to get this medication to have some delay in onset of diabetes.
So what are the new FDA approved medications? Is it the one that you just mentioned or what are we talking about here?
And so it's called Tzield is like the brand name. And its job, essentially it's 14 days of infusions. And it can be done in people who are 8 years or older who have 2 or more antibodies, who also have developed some difficulty managing their blood sugars. Like they're not all the way to having full symptomatic type 1 diabetes, but they're definitely headed that way and they're no longer able to make enough insulin. And so we know that it basically tells the part of the immune system that runs the T cells, which are out there doing the actual attack and eliminating the cells. And it tells them to like, hey, tolerate these cells, just turn a blind eye, quit going after them, just leave them alone, let them be. And so that's what it does. We know that it works for a couple of years. It doesn't work forever. And there's not a ton of studies looking at using it for a very long time. There are studies looking at whether or not can we use this when people are diagnosed, when they are symptomatic and they are needing insulin. Is there an opportunity to kind of settle down the immune system and leave those 10% of cells that make insulin there? Like, can we get the immune system to leave those alone? And so that's some of the new stuff they're looking at. There's a lot of other immune modulating therapies that they're working on currently as well.
Talk to us about the Wendy Novak Diabetes Institute and Norton Children's, the research that's happening there. That's pretty remarkable.
It is. It's a lot of fun and it's been cool. We've been really expanding at a pretty rapid rate. There's a lot of different things. So some of them are clinical. Some of them are like helping patients with glucose control in the setting of athletics, sports performance, helping them to manage their diabetes well and being able to do those things, looking at different strength modulation and things like that. There's a lot of disease modifying therapies that we are looking into, some clinical trials. We have a fabulous islet cell scientist named Dr. Bala who is here, and we're going to do a lot with some islet cell programs looking at islet cell function, dysfunction, and transplant.
All right. So what else am I not asking you, Dr. Montgomery, that you want folks to know about type 1 diabetes and the services that you all offer?
So you've asked me fabulous questions. I think just a plug to tell you that, diabetes is really hard. But we also work really hard with our patients and our families to make living with diabetes fit into their lifestyle, not flipping their life to fit into having diabetes. I think it's really awesome that we continue to expand and adapt and try to meet the needs of different patients, ranging from, your like 6-month-old all the way to those who are at the end stages of life and geriatrics who have type 1 diabetes and doing care in all of those segments and working together. We have a program that helps when you are transitioning from being a child and an adolescent into that adulthood where you all of a sudden are responsible for knowing your insurance information and making your own appointments and figuring out the very chaotic world of healthcare. And so we have a program where our diabetes educators work with our patients who are in their teens and in college to help them be successful as they navigate the world of healthcare moving forward, knowing it will be long-term.
And you all should know that screenings are also available for type 1 diabetes at no cost to eligible candidates between ages 2 and and 45 who have a relative with type 1 diabetes. That's important for folks to know.
It is. And so that's part of the trial net. So between 2 and 45, if you have a first degree relative, so a parent, a sibling, or a child with type 1 diabetes, if you're between 2 and 20, it can be a second degree relative, like an aunt, uncle, a cousin, a grandparent, et cetera, which can be it's very helpful.
Okay.
And there are people, we now know that there is an expanded timeline of when people develop antibodies and that autoimmune process starts. So everybody doesn't start at the same time.
Mm-hmm.
And so we now have the opportunity for some of these patients, if they screen negative the first time, to screen them again in a couple of years and monitor and see if there's any changes.
Okay. So if you need more information about this, contact 502-588-8910. Again, that's 588-8910 to schedule a screening or to learn more information. That can really help a lot of folks. Dr. Montgomery, what am I not asking you that you want folks to know about?
Well, I think that
it's manageable, right?
It is. It's doable. It is hard, but technology has been incredibly helpful in the way that we manage diabetes and helping try to mitigate the burden that comes with it. I think it's really cool to know that there are, in our office and across the Wendy Novak Diabetes Institute, the people there, we do diabetes for work, right? But we also spend a lot of time advocating for our patients and our kids with diabetes and adults with diabetes in the community, and volunteering, working in like diabetes camp, like Camp Hendon, and all kinds of other opportunities where we can be there physically with them outside of the office doing the fun stuff. Mm-hmm. And helping them to be able to do it successfully. Mm-hmm. is an incredible benefit. And I think just something really cool about our staff.
If you have diabetes, are you living with it forever, or is it something that you can get over this hurdle eventually?
So it is a lifelong illness, but there have been tremendous increases in the way that we can, or improvements in the way that we manage diabetes. There are now pumps that give the insulin and then continuous glucose monitors, and they talk to each other. And so it's really helped a lot with the safety of management of diabetes. When the blood sugar is rising, the pump can see that and can give a little bit more insulin. And then when the blood sugar is dropping, the pump can see that. And it's like, whoa, I need to pull back on the insulin, which is incredibly helpful. It is, because this has been a very challenging part, maybe the most challenging part of managing diabetes, especially in small children. Toddlers don't ever do what you say, exactly. And they don't do what they're going to say, right? And so trying to figure out, how much insulin does my kid need? Are they really going to eat what they said they're going to eat? How do I, kind of mitigate this? And then they decided they weren't going to take a nap. They were going to go run around for the next hour. Well, that changes everything, right? And so it's incredibly helpful and just fantastic to see the way that things have come and the way that we're able to improve the quality of life. So.
Okay, perfect. Dr. Montgomery, thank you so much for your time.
Thank you,
and educating our viewers today. All right. Again, if you need more information on scheduling a screening or to learn more information, contact 502-588-8910. And of course, visit the Wendy Novak Diabetes Institute as well for more information. Perfect. Thank you so much for joining us today. All right. I'm Myra Ansari with Dr. Montgomery. Have a great day.